So good morning, everybody, and I'm really pleased to welcome you to this session, which is featuring the best-in-class ideas projects from the first year of ideas, and we're doing this in a Pechakucha style, which allows each of the teams to present 20 slides, each slide for 20 seconds. And so that increases the pressure on our presenters and hopefully increases the speed of the presentation for you, creating a different sort of experience, rapid fire understanding of the leading projects as selected by a group that included some external stakeholders as well as some internal team members from the ideas group. So I'm Ross Baker from the University of Toronto. I have the privilege and the pleasure to co-lead the ideas initiative. We have funding from the Ministry of Health, and Stanley Brown is the other co-lead of this, and then we have a wonderful team of people who've really made this all happen. So I'm going to start with a bit of an introduction to this, to ideas. I'll do that relatively quickly, although I'm not on the same 20-second sort of timing, luckily for me. Our presenters have nothing to declare, and we have no commercial support, but wonderful support from the Ministry of Health and Long-Term Care, which we acknowledge. So we live in this world of turmoil. It's the perfect storm now for healthcare, not just in Ontario, but across the country, across the world. Every system is struggling with these issues about how do we improve quality and reduce costs or maintain costs. And I had dinner last night with Nick Barber, who's going to be our speaker at Moonshot this afternoon, and he was telling me some of the stories about England, what England's doing. England went from, I won't say worst, but close to worst to first in the Blair years, and now it systematically seems to be undoing the achievements that it really garnered through enormous efforts. So this is a struggle for everybody. The issues are in the nature of the changing population, in the nature of the workforce, in the expectations of people receiving care, in the requirements for the system to work in a 21st century style, and how do we do that with the resources that we have in Ontario. So a few years ago, 8 years ago, we did a series of case studies of high-performing healthcare systems, and we wrote a book, and I won't bore you with the whole book, but just to say that these systems all have some critical common elements, and among these critical common elements is that they prioritize quality and safety. If you focus on quality and safety, improvements of care, everything else follows. And that's a lesson that we learn from these systems. But to do that, you need to have a staff at all levels, middle management, frontline, senior leaders, who have the skills, the knowledge, and the confidence to work to improve performance within their system, and as we've seen recently with HealthLinks and others, to work across organizations to create better performing healthcare. Ideas, improving and delivering excellence across sectors is a 3-year initiative. We're in our 3rd year now. We're looking for additional funding to help to advance this agenda in Ontario and to build on the groundbreaking work of Brent James and his team at Intermountain, taking their curriculum that they've used for more than 20 years, adapting, modernizing, and improving it in the Ontario context. We're really fortunate to work with a variety of partners. I really want to acknowledge these partners because without the partnership, this would not be possible. HQO bringing the enormous skills that they have in quality improvement and some really excellent coaches into ideas to work with our teams. So the teams are learning and applying what they learn in their learning sessions on an ongoing basis, and the coaches are there for them in person and at a distance. ISIS has been a valuable partner as well. One of the critical issues in all improvement is data. Those of you who've worked in improvement know a big struggle to get reasonable data, first of all to establish whether you have a problem, and then secondly whether or not you're actually making some gains on improving your performance in that problem. So ICE has been a big supporter of our work and helping to translate and use the resources that they have. And then we're working in partnerships with the 6 medical schools and other academic units across Ontario to deliver the introductory program, the 2-day program, and that is another powerful partnership which we think will leverage into all sorts of other opportunities to improve curriculum, to improve training in those centers. There are currently two variations of ideas, what we call the Advanced Learning Program, the 9-day program, which happens over 5 months, cohorts of 40 and now more than 40 individuals who come as members of teams, partial teams, and several members come and participate in that experience, then go home and work with the rest of their team at home. And then we have a 2-day program, which is an introduction, more accelerated program, focused on other team members, not team leaders, to help them participate in this effort. Our goals are really to provide people with the knowledge it takes to do quality improvement. And having been working in this field for more than 20 years now, I have to say we greatly underestimate the challenge and the skills necessary for frontline staff to take these tools and to make a difference in their environments. So we work with them to understand the tools, but more importantly, to apply and use these tools in their environment to build the confidence and to connect with others doing the work that they're doing. Our goal is to help people learn, to do it, to share it, and sustain it. And so we're working largely on initiatives that have been prioritized by the ministry and their health system transformation agenda, and the teams now are providing not only an opportunity to develop individuals with skills, but to develop projects and learning that could be spread into other settings across the province. So we're trying to build a series of core competencies. You'll see them here. Quality improvement skills, adaptive leadership skills, the use of data, teamwork, project management, and change leadership. And then it's just the beginning of the journey, and we tell people as they come into this, so you're here for a 9-day program, but really we see your commitment as much longer than that, to become engaged in quality improvement on an ongoing basis in your own environments. So we're trying to create an ecosystem of quality improvement, partly through the ideas and through many of the other initiatives that HQO and others are leading in the province. We just had our Ideas alumni event yesterday, and more than 300 people in the room who are excited and engaged in these activities. So the future is there. I think we have an opportunity to reshape the way healthcare is delivered in this province, to change the conversation, change the language about how we identify problems, how we work on problems, to create a larger culture of improvement that will spread across Ontario and give us the resources, the skills, and the confidence to make a difference. We continue to move into new platforms. So we just launched our digital platform yesterday, and other ideas that come forward, trying to make these tools, these ideas, this community available to people across the province. So in this session, we're going to talk about some of these projects, and we're going to have the team members present their learnings. What did they learn? What did they do? What did they achieve in these projects? We went through a structured review of all the teams in the first year, and we gave awards based on the quality of the change ideas, the extent to which these projects engage patients, the learning that they achieved from using Pdsa cycles, and the capacity they built in their organizations to improve quality, to engage staff at all levels. So, having said that, I'm going to pass it on to Michelle to do the first presentation.
Thank you, Ross. So I'm Michelle Grinman. I'm an internal medicine doc, and I'm speaking on behalf of my team in the Integrated Long-Term Care Program that's based in the East Toronto Health Link. So we started this program, actually started based out of Toronto East General Hospital. And I just want to acknowledge my team members. So Kevin Edmondson, the manager of the emergency department at Toronto East General Hospital, and Ainsley Young was the nurse practitioner when we were in cohort 1. And we've since sort of changed our team, but that was our original team. So the title of our talk today is Building an Integrated Healthcare Delivery System for Seniors Living in East Toronto's Long-Term Care Home. And so I have I was in cohort 1, and so this is sort of year 2. So it's a little bit of a different format here. So I'm just going to get started with the case of Mr. R. This is an 87-year-old gentleman who came to the emergency department with C. difficile colitis, decreased level of care, and his family was really sort of pushing us to make him full code, so to really heavily investigate him and to really intensively manage him. And so the first 6 days of his hospitalization were quite chaotic. He had lots of tests, and he became quite agitated. And his family was seeing that he really wasn't benefiting from any of this. They started remembering that he had said he would never have wanted any of this care. He wouldn't have wanted to be in a nursing home. So when we aligned the goals of care, or we aligned his care with what he had wished before, he became more settled, and so did his family. Mr. R, as many frail elders from long-term care do, actually died of frailty, and more than a third of people die from this, but we don't recognize it often because the trajectory towards death is much more unpredictable than that of cancer or of multi-organ failure. The other thing that we know is that when we send vulnerable elders to the emergency department, they are much more likely to have a higher risk of mortality and a higher risk of morbidity. We also know that at least 25% of these transfers are potentially avoidable. And in Ontario in 2012, there were 82,000 transfers in the province, and that cost about $425 million. We also know that elders in long-term care are in the last few years of their life. And this is showing the cost of taking care of someone in acute care. The green and the red line are acute care, versus the blue and the purple are taking care of them in their place of residence. And you can see a huge divergence in cost at the end of their life. So to address the needs of vulnerable elders, and I was seeing it as an internist in the emergency department and in the hospital, so to improve their outcomes and their experience, and also for healthcare sustainability, we developed the Integrated Long-Term Care Program to bring services and specialists to long-term care and to improve quality, as well as to build an integrated system. So we did a needs assessment, and this was what we did while we were in cohort 1. We went to the long-term care homes and asked them about, what were their barriers and why were people being sent to emerge. And they found that the long-term care home is highly stressed, under-resourced, understaffed, and that makes it difficult to manage patients when they decline. The other major factor was that families, when they see their loved one declining, they feel very vulnerable. And if they perceive that the hospital is going to give better care, they're more likely to pressure the long-term care staff to send them. And so this became what we thought was an important factor in determining what's going to send somebody to the emerge unnecessarily. So our first Pdsa was to send our nurse practitioner to do proactive goals of care discussions, thinking that while there's no test for people's wishes, goals of care are like an ECG for your soul. So for the first 10 clinical days, the nurse practitioner saw 13 patients, changed the level of care in 6 patients. And what we found was, and so you can see, so the purple bars are pre and post the level of care, and the orange bars are emerge transfers. These are individual patients. And what we found is when she aligned the goals of care with the needs of the patient in the present moment, they went from going 4 or 5 times to the emerge in the prior year to no emerge transfers in the subsequent 6 months. And they were doing fine. When we checked in with them 6 months later, they were doing fine. After ideas, we continued this for 9 months. And we had to switch nurse practitioners our nurse practitioner moved away. So what we found is that the nurse practitioner was able to avert about 29 transfers in the subsequent 9 months, which is about $177,000 in savings to the healthcare system. We also found, though, actually I'll talk about it in a minute, a lot of this helped us to refine our paradigm for the integrated long-term care program, which rests on 2 pillars. One is capacity building, and the other is shared care. And it's supported by a foundation of quality improvement and change management, which, by the way, we learned from ideas. So, little plug there. But we found that the nurse practitioner had difficulty reconciling their role as a primary care provider with the MRP. So we switched to seconding a nurse from the Palliative Pain and Symptom Management Consulting Group to go to one of our pilot sites, long-term care homes, and do capacity building. She taught them how to do end-of-life care, how to identify when a resident is going to decline. She identified 16 champions that are going to become an in-house palliative care team. Concurrently, we deployed industrial engineering students to do a lean study and to optimize time for the frontline staff to be able to spend time with residents who are declining. So that was sort of the capacity building. Another theme throughout all the work that we've done is shared care. So we recognize that long-term care is unsupported, and we wanted to bring resources and specialists from the hospital to create a community of shared care. And we did that by leveraging telemedicine from the Ontario Telemedicine Network. Initially, our root cause analysis identified that palliative care was sort of the first thing that we need, our first priority. So what we've done is developed a network of 7 palliative care docs who are willing to do ad hoc consults and also monthly educational case conferences with the frontline staff and the physician. And in this way, create a shared community for care. But the other thing that we recognize is that when a resident is declining, the staff is going to call 911. They don't know whether this person is at the end of life or whether they just need episodic care. So we've partnered with the paramedics, and we're starting to develop a model for an alternate response model based on the successes in Nova Scotia and Alberta, where they've diverted 80% of emerge transfers. We then did major stakeholder engagement across Toronto and came up with a consensus for our model. And this is what we've proposed. So this is our future steps, which is to deploy our capacity building nurse in various hubs across Toronto and build in-house palliative care teams supported by our web of palliative care docs and the Palliative Pain and Symptom Management Consultant Group and the Emerge. And one of the things that the TC Lynn said to us is, well, is this going to be sustainable? Is this going to be cost effective? So we did an economic modeling exercise, and these are relative terms. But we compared usual care and episodic care from like an outreach team versus our model and found that there were huge cost savings in the several millions of dollars over 2 years. So this is my last slide. So our goal is to create an integrated healthcare delivery system that brings quality and increased capacity to long-term care. Right now, I think we're somewhere on the left-hand side, and hopefully every year I can tell you that we're getting closer to our ideal. And that's the end.
Hello, I'm Laurie Vantfort. I'm a physiotherapist at London Health Sciences Centre, and I attended IDEA's Cohort 3 with my partner Meredith Sharp, an RN on the unit, after we had just initiated a QI project to prevent functional decline. We had the honor of receiving the 2014 Alumni Award for greatest use of the Pdsa cycle. This is our problem, the hospital bed, and the amount of time that patients spend in bed. Patients often think that they need to stay in bed to recover. The reality is that they are losing strength and mobility, increasing their risk of complications, and quickly losing their ability to return home the more time they spend in bed. Our aim was to increase by 5% the number of patients discharged from our unit back to their own home. This would decrease the demand for rehab and long-term care beds, as well as decrease the number of ALC days in acute care. We knew that we needed to involve patients in normal daily activities to prevent a decline in their function while they were in hospital, recovering from an injury or surgery. We needed an interdisciplinary approach that was patient and family-centered, and we wanted to incorporate the principles of the Move On and Senior-Friendly Hospital initiatives. Our initial efforts were aimed at increasing staff awareness about the issue and providing education about how preventing functional decline on our unit could prevent complications and facilitate discharges home. An early staff experience survey alerted us to some potential barriers to success and helped to identify 2 important opportunities for improvement: team communication and collaborative care. The qualitative data that we gathered was used to guide our change ideas, and we were able to directly address some polarities amongst staff in order to help us achieve our common goal. We worked through a series of more than 20 Pdsa cycles. We began testing change ideas on small groups of patients involving only a few staff members and expanded to include the entire unit as we saw that changes were an improvement. Our main change idea was to increase the frequency that patients were mobilized each day. Because this was something that was not consistently documented or measured, we needed to develop a measurement system that was easy to use and not a duplication of work for staff. Using Post-it notes on patient doors that staff could easily record the times that patients mobilized allowed us to collect just enough information. Our goal for this process measure was to have 80% of appropriate patients mobilized at least 3 times per day. We have seen an increase from 17 to 85% of patients achieving this goal. From our control chart, you can see that we have experienced the challenge of sustaining our gains over time. As a fun and decorative way to encourage staff to engage families in patient care, we asked staff to use red sticky dots on a seasonal wreath each time that family members participated in care. The wreath was a visual reminder to staff to look for opportunities to get family members involved and allowed us to track our progress with this measure. Time wasted searching our long hallways for equipment and lack of appropriate equipment needed to mobilize patients were both identified as barriers to future improvements. Frontline staff were able to give input into how the alumni award money could be used to help sustain the gains we had made. Practical items, such as bedside commodes and transfer devices, were identified as the most needed items to sustain and continue our improvements. Having the right equipment in the room would mean more time for staff to assist patients with functional activities. The development of educational materials that would be accessible to patients and families at the bedside was also identified as a way to support the improvements on our unit, as well as facilitate spread to other areas through the sharing of these resources. So far, the spread of our QI project and our ideas experience has been through numerous presentations to other professionals, feature articles within the organization and the LIN, as well as consultation with other units who are working on similar initiatives and QBPs involving maintaining patients' function in hospital. Our lessons learned included the effectiveness of implementing small change ideas and the value of visual management to engage staff in improvement projects. Displaying the results of the mobility audit done yesterday was much more meaningful to staff than the discharge and length of stay data from 4 months ago. Our staff experience survey was initially intended to be a balancing measure to ensure that our changes didn't have a negative impact on perceived workload or job satisfaction. In fact, we were able to show an increase in all areas measured, including team communication and consistency in our approach to mobilizing patients. We learned about the importance of having support at all levels. Changes in leadership and competing priorities for frontline staff interfered with our progress at times. In retrospect, regular face-to-face updates with leadership to discuss progress and struggles could have facilitated further improvements. Failing to engage our early adopters in our working group has left me feeling like this modern-day one-woman band, carrying all of the instruments on my back. A project lead to handle the administrative tasks would have allowed frontline staff to do what they do best without carrying the full weight of the project on top of their regular workload. Spending money can be as easy as tap and go, but spending the award money has proven to be more difficult than anticipated. Sourcing equipment that meets our needs, conflicting advice from consultants, and lack of relief coverage for frontline staff have all slowed our progress over the last months. Because there is no finish line for quality, we will continue to test change ideas and look at new ways of drilling down the data we have. We are excited about opportunities to collaborate with other units and to improve the standard of care and meet our occupancy targets. Thank you.
Hello, I'm Gail Sudden from the Toronto Central CCAC, and my partners in this work are Dr. Jocelyn Charles from the Sunnybrook Academic Family Health Team and Anne Moorhouse, a GEM nurse at the Sunnybrook Emergency Department. We were proud members of Cohort 2 and went on to win the 2014 award through Ideas for Patient Engagement. And today we'd like to share with you how we have used that award and what we've learned along our journey. What we wanted to understand was why do people, frail elderly, come to the emergency department? Not why do we as clinicians think that, but why do the clients say that they are coming to the emergency? And our goal was to understand their experience, what happened before they happened to coming to the emergency, once they were in the emergency, and then once they went home. We looked at frail elderly who had many visits, 4 visits within the last 6 months, were over the age of 65. And we also built this work into using the existing staff, the GEM, the social workers who worked in the emergency to help with our recruitment. We also engaged the UHN Human Factors Lab, who conducted 20 semi-structured interviews. And these interviews happened right in the emergency as the people were waiting for their delivery of care, so it didn't interfere with that. Or in a couple of cases, the interviews happened after people had been discharged home from hospital. So what have we learned so far? We asked people, why did you come to the emergency department? And they said, because I'm really sick. They also said that healthcare providers suggested that they should come to the emergency department. And they said they came because they really didn't understand what their discharge directions were after their most recent hospitalization. We then asked, well, who did you consult before you came to the emergency department? And their answers were, they didn't consider other people. A few people chatted with their GPs, and a few people chatted with telehome care, and as you can see, a few people chatted with specific care. We asked them, when you chose to come to the ED, why did you pick that over other options? And they said that they felt that this was the best place to come for how they perceive their illness. They also said they had a previous relationship with Sunnybrook Hospital and felt that was very important in taking care of the continuity of their care. We also asked them, and I think this is very important to understand, is this a new issue or is this a different issue? And as clinicians, we can frequently look at someone and say, oh, this is the same problem you had last time and it's connected to this. But from the client, the patient, the citizen's point of view, it actually is something very different, and they interpret it that way.
So we were surprised to find that many of these patients actually did have strong relationships with their primary care provider and regular communication, and the vast majority had a family physician. Others did not have such a strong relationship. And we were also surprised that patients are feeling that they are engaged with their healthcare team outside the emergency department. And some are trying to be active, but they feel that the emerge is the only place that they can get their problem solved. We found it surprising that half of these patients came by ambulance, but what we found is that they were actually CTAS 1, 2, and 3. We thought they were going to be more CTAS 4 and 5, but they weren't. So speaking to Gail's point about their perceived severity of illness, they were right. So family bringing them in taxi were the other methods. So the factors leading to an emergency room visit were the family physician not being available. They felt their discharge from their previous episode of care wasn't helpful in terms of their self-management. They felt the emergency department was convenient and available, and time of day had something to do with that. And they felt they had chronic symptoms with no alternatives to the ED. And again, we were surprised by the number of times a healthcare provider advised them to go to the emergency department. And then again, there's their history of care at that hospital and assumption that there's where they get their continuity of care. And then the alternative options were either not desirable to the patient or not sufficient. There were other factors like a dependence on their family support with no redundancy built in. So if the family was too stressed, they brought them to the emergency department. Not a high level of comfort with technology. Transportation options not always easily available, but they did like home delivery and home services. So there are a number of complex factors that influence how patients select their care options and how system limitations actually do promote suboptimal choices by patients. So there needs to be tools developed to help patients navigate, but that are tailored to their specific circumstances. Just sharing a couple of cases. This fellow, names and pictures are changed. 82-year-old man living alone, no family, debilitating joint pain. He comes to the emerge when his joint pain is so severe he can't get out of bed. He has some communication issues. Convenient to come to Sunnybrook. He does have a regular GP, but has sometimes difficulty getting an appointment, and very appreciative of his community care from CCAC. And then another fellow who has a very supportive wife, well-educated, quite against CCAC, but feels this interferes with his independence. Looking for a GP, overwhelmed when given a list, really wants to look at alternatives for his medical problem apart from just coming to the hospital for drugs. So there needs to be a shift from this episodic care by serial providers to really a shared accountability and engaging patients and their families and providers across sectors. So we're now analyzing this data to hopefully inform the development of a tool to assist patients in self-navigating their own care plan. And so we are hoping to help them find alternatives to the eMERGE that are appropriate.
Good morning, everyone. It's my pleasure to present on our Cohort 3 Ideas project, which received a engagement award from Ideas in 2014. I'm here on behalf of the Toronto Western Hospital's Bariatric Surgery Program, and our project was created in an effort to decrease the number of patients who do not show up for their follow-up appointments. In terms of context, we receive 2,000 referrals per year for surgery and follow patients for a period of 5 years. We believe that by getting patients to attend their follow-up appointments, we could increase our patients' chance of long-term success, which we defined as sustained weight loss, continued remission of obesity-related comorbidities, and improved quality of life. This was our big aim. Our aim statement was the following. By July 2015, we aim to improve the post-bariatric surgery patient outcomes at the Toronto Western Hospital, defined as an increase in annual post-surgical appointment attendance by 30%. Through our time at Ideas and in consultation with our team and patient population, we worked diligently to determine what change ideas we should pursue. Quality initiative tools, including the fishbone diagram, impact effort grid, TRIZ, and Pareto charts, were hugely valuable in making our decision. It was determined that one of the major barriers to attending appointments, as reported by our patients, was A, parking costs, which we could do nothing about, and B, having to see all the clinicians at each visit, which could be up to a 4-hour wait, rather than just the ones that the patient felt that they needed to see. For this reason, we decided to change our follow-up care plan, which currently made visits mandatory, to one where patients were called in advance and asked which clinicians they felt they needed to see. The goal was to eliminate waste and to enhance the patient-provider relationship through personalized services. Another low-hanging fruit change idea included creating a handoff booklet for family doctors for patients who are doing well or who prefer to see their family doctor rather than the bariatric team. This was already being worked on by the bariatric team and undergoing Pdsa cycles with the family doctors. Implementation and dissemination of an online mobile site for patients to access information about their bariatric aftercare at the Toronto Western Hospital was also completed. Patients were asked to use this resource to support their self-management and to guide discussions with their primary care providers. Several outcome measures were collected and evaluated. These included percent of post-op patients attending appointments each week, percent of post-op patients canceling appointments in advance of their appointment with greater than 24 hours notice, and percent improvement in PHQ-9 scores for patients after surgery. Process measures included percent of post-op patients receiving advanced care planning phone calls and number of users visiting the online bariatric aftercare app. Balance measures include percent of patient satisfaction with the post-surgical care in the program and the number of pre-surgical assessment and post-surgery emergency appointments per month. We evaluated our data using Chart Runner. What we found was that advanced cancellation rates increased after implementation of the change idea, as indicated by special cause variation. However, there's no change in the no-show rate or total number of appointments attended. Confused by this, we did a deeper dive and looked at our process and balance measures. At this time, we saw a definite increase in the number of pre-surgical assessment appointments per week, as well as the number of post-surgery emergency appointments. From this, we were able to conclude that the increase in advanced cancellations freed up 8 appointment slots per week, which were being filled by preoperative assessments and post-operative emergency appointments. Data on the patient's experience of the intervention revealed the following. 1,587 patients, representing 5,676 appointments, were called between August 2014 to July 2015. 78% of patients reported feeling better, prepared for appointments. 73.2% liked being able to choose a clinician type they wanted to see, and 81% wanted to choose clinician type for all future appointments. It was felt that although we did not see a decrease in our no-show rate, the benefits of the intervention were worth continuing. We performed a cost analysis which revealed an approximate savings of $428 per week, or $17,500 of direct costs over the duration of our project, which was 41 weeks. Patient volunteers are now trained in making the pre-appointment care planning phone calls. This allows us to keep the cost of the intervention down and maintain momentum by using peer-to-peer volunteer training. Winning the Alumni Award has allowed us to continue to employ a project manager, which has been invaluable for data collection and analysis. It has also allowed us to share our learnings at the 4th Annual Canadian Obesity Summit and the International Forum on Quality and Safety and Healthcare in London, England. Quality improvement tools were introduced at our annual program retreat, which allowed for the entire bariatric team to tackle several program issues in a systematic way. The goal is to also spread our learning to centers within the Ontario Bariatric Network to help these centers run more efficiently as well. We could not have undertaken this project without the support of IDEAS, our bariatric team, our administrative support, and our patients. The bariatric program has an ingrained culture of innovation and change that allowed us to implement the changes with minimal resistance using a systematic approach. We are very lucky and grateful for this. And finally, what we have learned is that if data does not exist, start collecting. And if you aren't seeing the change you want to see, look elsewhere. Just because you weren't able to change the thing you were trying to, doesn't mean that you aren't still creating meaningful change overall. Thank you.
Hi, I'm Serafina Hui, Community Health Program Manager of St. Paul's Lamoureux Center. Myself and another program manager completed the Advanced Learning Program last year. Since then, we have worked as a team to with the support from HQO advisors, Eric Strong, and our center management team to transfer our QI learnings within and outside of our center. I would like to acknowledge the contribution of Melinda Lau to this project. She has just started her maternity leave this month. Our center is a nonprofit agency which provides community support services to older adults and seniors at the Northeast Toronto. We have 140 employees. This presentation will highlight the progress and our accomplishment in the last 6 months since we received the Alumni Achievement Award in the capacity building category. Our goal is to establish sustainable QI capacity by March 2016. Our first accomplishment is 50% of staff and 80% of board members complete a 7 to 10 minutes culture survey. The purpose of the survey was to assess the SPLC QI capacity. Staff and board members complete the survey either online or on a paper hard copy. The culture survey consists of 26 statements with the focus on 6 domains: QI knowledge, skills, ability, kind services, leadership, systems and processes, teamwork, and the use of data. The survey results show the strength of the center are the teamwork and the use of kind satisfaction data. The areas that we need to work on are QI knowledge, skills, and QI structure. Also, we need the participation of leaders. Our second accomplishment is all staff and board members have access to QI training and QI resources. As of today, 10 interactive QI training sessions, mostly in 1 hour, have been offered. In our training session, everyone has a chance to share and talk about QI, their thoughts, ideas, and discuss the strengths and issues that they face every day. We use the Adult Day Program Utilization Improvement Project, which all staff and board members can easily relate it to as an example to illustrate the QI concept and approach. The key message, QI requires hard work from an interprofessional team. QI principles is in alignment with our center mission, vision, and values. The training outline includes why QI, what is QI, the definition and scope of QIs, and how to do it. Through the training, everyone across the organization learned the QI methods, the common language in QI. Participants had hands-on experience on QI tools. The training materials are posted on intranet. Also, we are setting up QI kiosks. It will be easy for our staff to find resources and receive QI update even if they have no access to internet. Our third accomplishment is we have spread the Adult Day Program Utilization Project change ideas to 3 other day programs. The phone reminder intervention strategies, and the new category of tracing cancellation reasons. We continue to monitor the data of all day programs, share data with the teams, and to find areas for improvements. Our fourth accomplishment is from the real example. Staff are attracted to join the training. So over 50% of our staff has joined the QI trainings. Their feedback, over 80% of them rate the training session good or excellent. They indicate the learning were useful and relevant. Last year, we only have 5 staff involved in QI. Now we have over 80 staff members gain some knowledge and skills in QI. Staff also shared what they have learned from the QI sessions. They gained knowledge on QI related to the aim statement, Pdsa, and the family of measures, the process, outcome, and balance measure. They also learned from the shared experience and challenges. The QI training has drawn the attention of board and staff to QI. Several members have expressed their interest to join our new QI committee. This is our proposed QI structure in the organization. The QI committee will develop QI plans and QI projects based on the issues and challenges identified. We'll utilize existing data from IHPME, EMSA report. We will continue to engage our board, staff, volunteers, and caregivers to develop and test change ideas. We believe by March 2016, SPLC will be able to establish sustainable capacity to drive an organization culture of continual quality improvement and excellence. Thank you.
Good morning. Our team is from Markham Stouffville Hospital, and we were in cohort 2 of the IDEAS program and won the Building Capacity Award last year. My team is here with me. My name is Sandy Lofgren, and I'm the Director of the Uxbridge Site in Corporate Clinical Informatics. Clint Attendido is the Director of Emergency and Surgical Services, and Loretta Morrison is the Manager of Inpatient Surgery. Markham Stouffville is a 245-bed community hospital that's recently undergone a major expansion and renovation project that more than doubled our size. Before construction, we were seeing approximately 68,000 visits to Emerge per year. Post-construction, we've seen an 18% growth over 3 years. The increase in ED visits and the controlled opening of additional medical beds with PCOP funding challenged us to maintain acceptable patient flow and access to inpatient beds. The focus of our project was to improve patient flow from our overcrowded emergency department to the inpatient unit by increasing the number of medical patients discharged by 11 a.m. With this rapid growth, our Emerge was like a pressure cooker. We had ambulances on offload delay, patients in the hallways. Our 90p length of stay for admitted patients in the Emerge was more than 42 hours, and patients were telling us that this was unacceptable. We were also not meeting key metrics such as our QIP targets, nor were we capitalizing on pay-for-results funding. As we did a deeper dive into the issues, and as this graph shows, most discharges on medicine were after 3 o'clock in the afternoon, resulting in delays in transfers from the ED until the evening when support services were at their minimum and decreased staffing levels. The aim of our project was to increase the percentage of medical patients discharged by 11 o'clock from 13% to 30%, or essentially just 1 to 2 patients per medical unit. Staff and patients were consulted about the most appropriate early time for discharge, and most patients indicated that if they were well prepared ahead of time, they were quite happy to go by lunch. Analysis of barriers to early discharge showed us that one of the major problems was that physicians were not able to attend patient rounds on the medical units for various reasons, which caused delays in receiving pertinent updates and then writing orders for discharge. Input from physicians indicated that if we standardized the bullet rounds and made them more concise and discharge focused, they'd be more likely to attend. Our process and outcome measures included the number of physicians who attended bullet rounds and the number of nurses who used the standardized bullet round documentation, as seen here on our electronic status board. To further embed the 11 a.m. discharge idea, we used visuals like this safety cross to communicate the team's progress in achieving our overall aim. Staff were familiar with this tool for tracking in other metrics like falls rates, and we posted these safety crosses on our quality boards and discussed them every day at our 10 o'clock bed meeting. Many lean events took place to analyze the current state and design a desired future state. We identified waste and variation in practices and then took steps to make improvements. The lean events also presented an opportunity to build relationships between the ED and our inpatient units. Unwavering support from our executive sponsor and a directive from the senior team to improve patient flow and access to care enabled us to achieve our aim. Physician partnership and governance by a corporate flow steering committee were also enablers, as was our desire to optimize our pay-for-results funding and to meet our QIP target of improved patient satisfaction with the length of stay in the Emerge department. Our flow steering committee, which has representation from multiple programs, physicians, and senior team, then prioritized the increased funds received based on the need to support flow and the 11 o'clock discharge. And this is just a list of a few of the initiatives that were taken on. A nurse practitioner, an additional patient flow coordinator, and a manager of access and flow. Recently, we opened a short stay medical unit, and we wanted to spread the successful flow initiatives to this new unit. We used our award money plus some of the P4R funding to support implementation of an NP role on this unit, the purpose of which was facilitate patients being discharged by 11. In order to equip the NP to support the team in implementing the same flow processes as the other medical units, she attended the 2-day IDEAS program in order to learn the same QI methods and language that we learned in the advanced program. Our results, we have struggled for a few months with the 30% target, but our latest results show that the 11 a.m. target was again met and has been sustained across the medical unit since opening our short stay unit and implementing the NP role with the focus on early discharge. And these two next graphs show the improvement in the ED length of stay for admitted patients. The latest results are showing that we're below our QIP target of 30 hours. These results can mostly be attributed to the various Pay for Results funding initiatives started in April of 2015, including the opening of the short stay medical unit and the nurse practitioner role there. We are constantly challenged to stay on top of things. As with every organization, there were and continue to be many competing priorities for the organization. Things like Ebola preparedness, flu seasons, ongoing issues with ALC numbers, other priorities on our QIP, all have diverted attention from the focus on early discharges. Recently, we've had to reiterate the purpose of the NP role on the short stay unit. The physician team got excited about the role, hoping for an extra pair of hands to help with the heavy patient load on the other medical units. We are also challenged to place appropriate patients on this unit. Word has gotten around that the flow is faster and more coordinated on this unit, so the physicians are requesting that all of their patients be admitted there. Our improvement plan for the next 6-month period includes having a consistent NP on the short stay unit for the remainder of the year rather than having her rotate through all the medical units, clarifying the purpose of the role with all stakeholders, and refreshing our commitment to the 11 o'clock discharge idea. It remains a priority action item on our QIP again this year. Thank you.
So thanks to all the presenters for really giving you a flavor of what the ideas projects were like, and for dealing with this challenging format of presenting them in a very brief, condensed fashion. So I'd like to invite everybody up to the stage from the teams so that we can have a dialogue with you in the audience. And if anybody in the audience has a specific question for one of the teams, why don't we start there? Anything you want to know about one of these projects? What the focus was, what the changes were, what the results were, how to build that, and then we'll move into a broader sort of discussion about spread and sustainability. Any questions for any of the teams? Yes. Safety cross.
Oh, the safety cross. I've had a lot of questions about the safety cross, actually. We've used it at our hospital for mapping lots of our metrics that we're trying to reach. So each cross represents 1 month, and the numbers on the cross are the numbers during the month that they meet the metric. And there were a few colors. I mean, I made up that safety cross, but if we met the 11 o'clock discharge that day, our 30%, it was a green. And then we figured out if it was a yellow or a red. And slowly we did see the crosses. Our manager of access and flow is here, and she's the one that actually profiles the crosses at the 11 o'clock bed meeting every day. And we saw them changing from mostly red to mostly green as we were meeting our metric. It's a really good visual for our hospital.
Other questions for the team? Yeah, Lynn.
So much. Is it on now? Okay. Thanks so much. I loved your focus on how different interprofessional team members can talk to each other and communicate. One of the great examples was the discharge focus bullet rounds. And I wondered if you could just tell us in a minute or two what that looked like. How long was it? Who was there? How did you maintain that? Any lessons learned?
Sure. Would you like to speak to it, Loretta? Okay. So Loretta is our bullet round queen at the hospital. She's the manager of surgery. So on all of the units, and we did try to standardize from unit to unit. We had managers and interprofessional team members go to different units and see what the variation was in the rounds, in the bullet rounds. But typically on our surgical unit, the whole interprofessional team will gather around that electronic status board. The nurses have input all of their metrics ahead of time electronically so that they show up on the board for everybody to see during that very short period of time. And then they all listen to what the barriers to discharge are as perceived by the team. Every member of the team, whether it be allied health services, whether it be nursing, physicians attend, are able to speak to what they perceive as the barriers are to discharge. And then right then and there in that forum, those barriers are discussed. What needs to be done in order to move this patient forward to discharge either today, tomorrow, whatever? What needs to be done to get this patient out by 11 as opposed as to out by 5 this afternoon?
Great, yes.
I had a quick question about the, was it bariatric surgery? And that, yeah, hi. I missed your points on how care was improved and actually the cost savings. Because I looked up and I went, wait, what? Just by, increasing follow-up appointments? I wonder if you could touch on that again.
So we have two sets of patients who come through our programs. We have the pre-op patients who have to do a number of assessments. So every patient has to see at least 5 different clinicians from each of the disciplines. We follow patients for a period of 5 years. So once they've had surgery, they then come at different time points to visit with clinicians. So by decreasing the number of cancellations, so we're calling patients ahead of time saying, are you coming in to see all these clinicians? If not, who would you like to see? Those ones that they said that they don't wish to see, that frees up slots for those pre-op assessments or for emergency cases that happen. So the way that we did the financial piece is we looked at the average cost of a clinician visit and then translated that to lost time essentially. So for every hour that clinician works, it's an average of, amongst all the clinicians, about an average of $55. So that translates to 55 times, 8 slots per week, $428 per week. And like I said, over the course of the project was $17,500.
Okay, so I'd like to turn to some broader issues across these projects because as you've seen, it's really diversity of the kinds of aims that the ideas projects are focused on, the sectors that they're in, the change ideas that are introduced, and the results. And part of our goal here is to not only build the skills of individuals and the immediate results, but to find ideas that may be useful in that setting and in other settings. So I want to open this up for discussion among the team members here. You've been out of the program now for more than a year. You're still thinking about these issues and working on it. What's important in terms of maintaining a focus and helping to move forward with these projects? Because you're all sort of mid-stage, right? You've made some improvements, you've learned some things, but you're not finished yet. So how are you continuing to engage your staff in your organizations? Anybody want to try that on? Yeah.
I'll start with that. One of the presenters today showed a slide that showed some really rickety scaffolding, and I think that's a really key thing, that you need to have your senior leadership fully engaged, and we heard about the QBPs and all the other things that are going on in the health system, but we need to be continually linking those metrics to quality improvement and holding ourselves accountable and being held accountable to a quality improvement agenda. And I think that's the way you sort of embed this and move it from being an activity we're doing at the side of the desk to actually being the DNA of the Ontario healthcare system.
I'll comment. I think the other piece is utter perseverance. I think there are many times when you think, okay, we're done. Time to stop. And you realize that, I love the staircase. I can't remember who had that staircase. It never ends. We just keep going. What's the next idea that we have to move this project forward? And I think that helps energize the team.
So I think, so our project is a little bit different because my team actually was not employed in long-term care homes, and we were sort of being deployed out. And so in what we recognized as a team is that we had kind of a common passion for what we were doing. And then we also changed up our partners, and we were quick to adapt because we had to try things out, see what the long-term care homes would kind of accept. So I think perseverance for sure. I also think that one of the issues that we've had, and it's interesting when Danielle Martin was talking about pilot projects, that because you get seed funding and then that ends and you get another seed funding, you're constantly retraining like your program managers. Like we ended up needing to use some of the ideas money to keep our program manager to do all the things that we needed to do. So I think that definitely helped us, but I think also a common purpose for the team that was working.
Well, as I alluded to in my presentation, I think it's a commitment throughout the whole organization. And one thing I've seen at Markham Stouffville is a real commitment to the shared governance model. So we do have that corporate flow steering, and the pay for results funding that we get. It's very clearly not sunk into one program or the other. It's not a benefit of Emerge doing everything that they need to do. It's shared throughout the whole hospital. Every program gets a piece of that money, and it encourages us to work together as a team and to apply all these principles of making things better as a group. And so it's not owned by just a few individuals at the hospital.
I think for our program, one of the main drivers is making sure that we're providing the care that our patients need. So it's striving to bring them back in for those appointments, because we know what the statistics say, that if patients aren't followed up long term, that they can regain weight and suffer a lot of complications. So it's making sure that we can bring those patients back in, provide the services that they need, but do it in a process that's streamlined and meeting their needs.
For our projects, we keep track of the data. So we share what's happening related to cancellation and the change condition with clients. So even we don't focus on, like we stop the reminder call, because the group of clients that were in the program, like some of them were discharged. There was one that we identified that need to refer to other programs. So we didn't have the same group of clients. So we focus on other aspects of improvement, like fast track the admission, simplify the procedure.
Okay. So one of the interesting things I've noticed across these projects is that although we focus on the quality improvement tools, the changes often require changes in the way in which teams are working, changes in roles, changes in communication, changes in the sort of daily work of individuals. And sometimes it's adding people, sometimes it's changing responsibilities, sometimes it's just changing the way in which people talk about the patients, the clients they're seeing. And that's, as we all know, can be a huge barrier, because people get very committed to the way in which they work and not always committed to this idea that, they're open to changing that. So I'd like to welcome reflections from anybody in these projects. What are the changes you saw in the way in which staff were working together, or in the way in which staff were relating to patients, that came out of this, that may not have been the initial intention of your project, but emerged as kind of interesting developments as you got into the project? Any thoughts about that? Yeah?
I think one of the most interesting things about our project is it's actually a partnership between 3 distinct organizations. So we don't have a common family that we all report to. And one of the things that I found most interesting is how people move from "this is my patient" to the conversation about "this is our patient." And that was some of the really dramatic things. And the other thing, when you mentioned about changing roles, we're introducing a new role into this project that has, if you're an administrator in the group, you'll appreciate some of these comments. We're dealing with multiple unions, multiple organizations, role descriptions, and all this stuff. And basically, everybody came to the table with the same philosophy, which was, how do we bring this role into reality? What will it take to be successful, versus telling me what all the problems are? I had some awareness of what those might be.
In the bariatric program, we're very lucky. It's a great team of interprofessionals, so we're used to working together on projects. I think the new role that was introduced, Vincent, our project manager, has been phenomenal. And the other role that we introduced was the patient who does the telephone calls for us. So bringing her in, learning from her what her needs are, has allowed us to create other opportunities for other patients to become involved, because they have told us before that they want to give back to the program, they want to be able to help us out, and so this is a perfect opportunity for them to do that.
We really learned about the importance of communication. We realized that although we were working as a team, we weren't really talking to each other. And once we started to do that, rather than just make assumptions about what another team member was doing, when we actually talked about it, we were very intentional about it, we could do better care planning for the patients. We definitely saw that our results were much better.
From the project, like when we share, and when we have the training, one of the key issues, like everybody talk about, is limited funding, understaffed, under resources. So we have to use this QI ideas and methodology. We still can do better based on this methodology and principle. So that is one change that we noticed, that people start thinking, okay, without additional staff and funding, we still can do better.
So for our program, what we realized as we were going along is that everything we were doing was about relationships. So when we first deployed our nurse practitioner, we were really surprised at the end of the 10 days, about 2 weeks after we finished ideas, we found that the physician in the long-term care home had gone on vacation. The nurses had already identified patients or residents who were declining, changed the goals of care themselves, and then called our NP to help with end-of-life care, which was a switch in her role. And we were like, we're already kind of changing culture. So we found that really interesting. And then when we started doing the educational case conferencing, we had initially actually targeted at the physicians. So we brought the frontline staff, but our goal was to get at the physicians. And what we found is that because the frontline staff were there, they started actually taking ownership of the whole session and teaching the physicians rather than the palliative care doc via telemedicine. It was actually the frontline staff. So we found that that we keep finding the relationships keep changing as we're going along.
I think for us, again, like Lynn was saying, it's the interprofessional team and how we can all work together to accomplish that goal of an earlier discharge. It's not really just up to nurses to get their patient ready to go. And it can all start, well before that day of discharge by the whole team having the same shared goal to get this patient ready for discharge.
Great, thank you. So one final question for our teams, and it's building on Daniel Martin's idea about spread and scale. We've heard that these projects all took place in defined settings, but there's lots of interesting ideas that emerge from this and lots of opportunity to do these kinds of things in different settings. So I want to ask each one of the teams, so what one piece of advice would you have for somebody who is trying to take your project on and move in the same direction that you're trying to move in order to make this faster, quicker, more successful, based on your experience? Gail, do you want to start with that?
I think Jocelyn.
I think we need to listen to our patients and understand what it is they need from us to help their care. I think we do too much to people instead of helping them help themselves. And I think we learned that hugely through this project, and we're hoping to develop a tool to help other patients be able to express themselves as well.
I think for us it's to not get stuck on what your measures are. Like if you see that things aren't going your way, take a step back, re-examine, and look at what you have found out of it.
I would suggest to use that 5W2H tool, those simple questions that we can ask every day from frontline to board level to apply that to any project.
And I would agree with what Sandra said. We did not achieve our aim mainly because of the delay in obtaining the data. We have a 4-month delay in discharge data. But what we did see was that increase in staff satisfaction, which was not something we were expecting, but very meaningful for us, and we can carry that through, I think, to other areas of quality improvement. So it is important to look at all aspects of it and see the improvements and give yourself credit for those improvements, even if it's not what you set out to do.
Those things resonate with me. I think for me, when you guys were saying go slow to go fast, I didn't really get that during the ideas because I just wanted to go fast. And then, a year later, I'm still sort of modifying my model. And I think that it's been valuable that we keep going back to our root cause analysis. So I think that's actually grounded us and helped us to move forward.
And I would reiterate that. I think just a commitment to what we're doing and why we're doing it. It's for our patients. And to continue, like some of these other people have said, continue to look for the small change ideas. So if it's gotten stale, if it's not working, if you're experiencing the ups and downs, there may be other ideas that you can apply to continue on reaching the goal.
So before we close the session, I want to acknowledge some people in the room who have been really a vital part of this. Here, Vivian Yu and Christine Shea and Jillian Ritzy, would you stand up, please? And Cynthia Majeski, please. In the design of this program, there are many, many people who have contributed to that, and so we need to acknowledge that broader community. So you've heard some amazing stories in different kinds of environments. It's really the start. It's really the setting the ball in motion, I think, but understanding more deeply the systems in which we're working, which we assume that we know, right? As clinicians and as managers, we assume, and then we discover the complexity and the issues, and that gives us a better way of thinking about how to influence the results, how to influence the performance. So I think that's the critical knowledge that we get from quality improvement. It looks really small scale, but it's that initial understanding of what's happening in the system that gives us the opportunity to go in and change the system to improve it and to build support, to build commitment among the staff who now see that things could be different, things could be better for them and for the patients we serve. So thanks for everybody. A round of applause for these teams. Thank you all for your attendance. Come up if you have other questions for the teams. I'm sure they'll be able to stay and answer them.